about how we can try to ensure that the care that we provide to atrial fibrillation patients is centred upon the patient. These are my disclosures. So the latest ESC guidelines for the management of atrial fibrillation advocate an integrated structured approach along 5 domains to try to ensure that there's hemodynamic stability, reduction in overall cardiovascular risk, a reduction in stroke, and also improvement in patient symptoms in relation to rate and rhythm control strategies. So this translates into expected benefits to the patients in terms of improved quality of life and improved life expectancy, and there is data that shows that there are improvements in both these domains. And as Jerome has just very nicely illustrated, integrated AF care with multidisciplinary teams, use of complex IT systems and innovative technology tools, with access to all appropriate treatments for atrial fibrillation patients actually translates into improvements in guideline adherent AF treatment and also hard clinical endpoints in terms of reductions in cardiovascular hospitalisation and death. But central to this, as Jerome highlighted, is patient involvement, and particularly patient education and shared decision making. So if we truly want to provide patient-centred care, we need to have an understanding of how atrial fibrillation affects each individual patient so that we can provide tailored care for our patients. So at the last EHRA AFNET consensus conference here in 2015, the document highlighted some quality criteria for an atrial fibrillation service, which I've summarised here, and I just want to draw your attention to just 3 of these. So one of the most important things is that we have sufficient time with patients in order to provide them with adequate information and education about treatment options. The guidelines advocate an individualised approach to decision-making, with shared decision-making being the approach preferred. Improving patients' health literacy, that of patients and their caregivers, is extremely important, and we need to ensure that any information and education that we give is tailored to the patient's ability to be able to understand that information and also their desire for information. And it's very important that when information is given that we check the patient's understanding of that information. And obviously providing a structured follow-up plan is also essential in order to provide patient-centred care. So atrial fibrillation is a chronic condition, and for the majority of patients is going to require them to adhere long-term to medication and also lifestyle changes. And the success or failure of atrial fibrillation management is largely dependent upon the patient's willingness and ability to adopt and maintain these behaviours. But the majority of AF patients have very poor awareness of atrial fibrillation and are unaware of the associated increased risk of stroke with AF, particularly when they're first diagnosed. And most patients who are newly diagnosed will have very little knowledge about the available treatments to them. So in order to ensure that the care we provide is patient-centred, we need to have some understanding of the impact of treatments that we offer patients. And this is some information from a European patient survey on atrial fibrillation patients that was conducted in 5 European countries in about 1,500 patients. And factors which adversely affected patient satisfaction was lack of engagement in medication reviews, lack of patient education, and lack of involvement in decision-making and self-management. So for the next few slides, I'm just going to focus on how we can provide patient-centred care in relation to oral anticoagulant therapy, since the majority of AF patients will require oral anticoagulation. So as you've seen in previous presentations, we need to appropriately risk stratify these patients for risk of stroke and risk of bleeding on treatment. And we also need to be aware of what's the most appropriate oral anticoagulant treatment based on the patient's risk profile and also taking into consideration patients' preferences for treatment. So there are a number of technology-assisted decision-making tools for healthcare professionals, and this is just a couple of examples of 2 apps that are available. So on the left-hand side is one from Hong Kong University, which has a number of risk assessment tools readily available. And on the right-hand side is the ESC Catch Me Consortium healthcare professional tool. And I'm not going to talk any more detail about this because Larissa will cover this in the last presentation in this session. So in order to be able to provide patient-centred care, we need to understand what outcomes are important to the patient. I think this is nicely illustrated in this Canadian study by Stephen LaHaye and colleagues. And so they asked patients what their attitudes were towards stroke prevention and bleeding risk, and asked them to rate how they felt about minor, moderate and major stroke, and also major bleeding on a health utility scale. And they also asked the patients how many bleeds they would be willing to endure in order to prevent one stroke. So if we look at the graph, this is the health utility. So a health utility score of 0 is equivalent to death, and a health utility score of 1 is the best health imaginable. So patients rated a minor stroke as worse than a major bleed. A moderate stroke was rated as only just marginally better than death, and a major stroke was actually rated far worse than death. So stroke prevention for the majority of patients is their number one consideration. Also in this study, it's important to note that 12% of the population were actually medication adverse. They would not take oral anticoagulation even if it was 100% effective at preventing stroke. But patients who were willing to take anticoagulation were willing to endure 4 major bleeds in order to prevent one stroke. So understanding what outcomes are important to patients will allow us to provide patient-centred care. So as I said earlier, shared decision making is the approach that is preferred, and this involves a two-way exchange of information and involvement of the patient in treatment decisions. But it's also important to note that patients will vary in how much or how little they would like to be involved in treatment decisions. And I just illustrate this in terms of patient preferences for involvement in oral anticoagulant treatment decisions. And this is data from a recent international patient survey. So if you just look at the first column here, this asks patients to rate how much they would prefer to be involved in treatment decisions. And you can see that 45% of the patients preferred the doctor to make the choice about the oral anticoagulant therapy, 36% preferring to make a joint decision in conjunction with their doctor, and only 1 in 5 of the patients preferring to make the decision themselves. So having those discussions with patients to sort of ascertain how much involvement they would like to have in treatment decisions is important. Now obviously, in order for patients to be able to take part in informed decision making, they need to be able to understand what they're signing up to. And it's obviously important that patients are educated about what atrial fibrillation is and what their own individual risk of stroke is and the risk of bleeding on treatment. And obviously how we present risk information will colour whether people decide to take medications or not. And this is just an example of how you could engage with the patient in terms of discussing anticoagulant therapy. And this is from the NICE guidelines, the patient decision aid that's used in the UK. On the left-hand side is for patients with a CHA2DS2-VASc score of 2 who receive no treatment. The red faces show those patients who would experience an AF-related stroke. And on the right-hand side, we see the benefit of oral anticoagulant therapy, with the yellow faces showing how many patients would be saved from having an AF-related stroke if they took anticoagulation. And there's also similar pictograms for use for bleeding risk too. So as Jerome said, increasing health literacy by educating patients is key, and I'm not going to go through this in the interest of time, but these are some of the key topics that we should be focusing on when we're educating patients. And obviously taking every opportunity, so every contact with a healthcare professional, whether that's a doctor, nurse, pharmacist, whoever it might be, to reinforce the information and check that the patients are understanding what you're telling them. So patient education can be facilitated through checklists such as this, and this is an example from Hein Heibuchel's paper. I use a very similar checklist to this when counselling patients for oral anticoagulation therapy in clinic. And this just highlights, this is just a portion of this checklist, highlights the key important things to check and discuss with the patient. And I find that by formalising the process, by going through a checklist and asking the patient to sign it, increases awareness of the patient of how important oral anticoagulation therapy is. So in addition to giving verbal information, it's also important to provide patients with other resources to take away with them, or things that they can refer to at a later stage. And there are obviously written information, there's also booklets, websites, and obviously the more recent innovative apps. So this is just a few examples of some written resources. So cardiology patient pages on taking the NOACs. Industry have also developed very nice education booklets for each of the NOACs. And this atrial fibrillation oral anticoagulation card is available from the practical guides, and this is something that the patient can take between the different healthcare professionals that provide care to them. EHRA also has a patient AF website, that's AFib Matters, and this is now available in 7 languages. Obviously, patient organisations also have very good websites, so like the Atrial Fibrillation Association, Stop AFib, and AFNET. And also, the ESC Catch Me Consortium has got this new smartphone application for atrial fibrillation patients. So this covers AF information and also the patient's medical record in relation to atrial fibrillation. And again, Larissa will go into this in more detail shortly. So ladies and gentlemen, to conclude, implementing patient-centred care for oral anticoagulation in atrial fibrillation patients requires that physicians and healthcare professionals managing patients' care are aware of the latest clinical guidelines and are able to correctly identify patients who require oral anticoagulation through appropriate risk assessment so that they can select the most appropriate oral anticoagulant drug based on the patient's risk profile and also taking into consideration patients' preferences for treatment. It's essential that patients receive tailored, individualised education relevant to their treatment programme. And with oral anticoagulation, they need to receive specific information about the drug. Adherence is obviously key with oral anticoagulation, and patients must be aware of the potential consequences of non-adherence. We need to ensure that we regularly review risk factors because these are likely to change over time and may necessitate changes to AF treatment. Continuity of care by a dedicated AF team promotes patient-centred care. And lastly, but by no means least, incorporation of patient-reported outcomes as outcome measures in trials and also in clinical practice is necessary to assess the impact and the quality of AF treatments on patients if we truly want to improve the care we provide to our patients. Thank you.